So, usually when you have surgery, the expectation is kind of just finality.
Right.
Like you get your appendix taken out and you never have to worry about your appendix ever again.
Right. Yeah. It's just gone.
Exactly.
Yeah.
The problem is definitively solved.
Yeah.
And you just, move on with your life.
We definitely tend to view the operating room as this place of permanent fixes. I mean, you cut out the problem, you close the incision, and the narrative is supposed to just end right there.
But stepping into the world of endometriosis, that
Yeah.
sense of finality just completely vanishes. It's much more like weeding a garden where the roots are entirely invisible.
Oh, that's a really good way to put it.
Right, because you wake up in recovery, the doctor stands at the foot of your bed and says, hey, the surgery went great. But there's this nagging, anxiety-inducing question that sets in almost immediately for you. And that question is, will I have to do this again?
And it is arguably the single most pressing question patients have after an excision surgery.
Yeah.
And historically, I mean, the medical field hasn't offered a great answer for it.
We really haven't, right?
No, we've relied so heavily on short-term data. Looking at outcomes maybe 1 or 2 years out, or we've just relied on anecdotal evidence from patients.
Which isn't super helpful when you're trying to plan your life.
Exactly. We haven't had clear, long-term roadmaps to show patients what the entire life cycle of the disease might actually look like over, say, decades.
And that actually brings us to the mission of this deep dive. Because today we're examining a really comprehensive 2023 study, and this was published in the journal Fertility and Sterility.
It's a fantastic paper.
It really is. They tracked 1,092 patients over a 10-year follow-up period. I mean, for anyone navigating this disease, finding 10 years of longitudinal data is, well, it's basically finding the holy grail of medical research.
It really is. The sheer scale and the timeline give us this incredibly rare opportunity to move past those short-term snapshots we were just talking about.
Because it's hard to fund a 10-year study, right?
Oh, absolutely. Endometriosis affects millions of women globally, yet long-term surgical outcomes remain notoriously under-researched, often because, tracking patients for a decade requires immense funding and, honestly, just administrative dedication.
So this deep dive is going to give you, the listener, a much clearer picture of what the future actually looks like post-surgery. And this is backed by hard data, rather than just guesswork.
Exactly.
But before we start looking at the results, we need to establish who we are actually looking at. Because the parameters here are incredibly unique.
They are.
This isn't just a random sampling of patients pulled from dozens of different clinics with, varying surgical protocols and skill levels.
Right. The cohort is highly specific. We are analyzing those 1,092 patients who were managed for endometriosis between June 2009 and June 2018.
And this is at the Rouen University Hospital in France, right?
Yes, Rouen University Hospital. And the crucial detail here, the thing that really sets the stage for all the data, is that every single one of these surgeries was performed by one surgeon.
Okay, let's unpack this for a second. Because if we're only looking at a master surgeon treating cases with top-tier MRI mapping, how does this help the average listener?
That's a fair question.
I mean, if you're just going to your local hometown clinic, isn't this data completely skewed?
It might seem that way, but what this actually does is isolate the biology from the surgical technique.
Oh, I see.
Right, so by tracking a highly experienced specialist whose explicit goal in every single procedure was the complete excision of all visible macroscopic lesions, we basically eliminate surgical error.
Or incomplete excision, right. So we remove those as major variables.
Exactly. We are essentially looking at a best-case scenario for surgical execution.
Like evaluating the reliability of a specific car model, but only looking at cars that were restored by the world's absolute best master mechanic.
That's a perfect analogy. It sets a baseline for the true recurrence rate of the disease itself, rather than the failure rate of a suboptimal surgery where, lesions were just left behind.
And I think it's important to note that these were not mild cases at all.
No, not at all. Nearly 84% of these women had deep endometriosis.
Wow.
Yeah, and get this, a staggering 58.4% had severe endometriosis infiltrating the rectum.
Over half had it in the rectum. That is incredibly severe.
Very severe. And every single patient was assessed preoperatively with an MRI, so the surgeon wasn't just going in blind.
Right.
The MRI dictated the surgical approach, which allowed them to map out those deep infiltrating lesions on the bowel before making a single incision.
Seeing that level of severity makes the tracking even more significant, I think.
Uh-huh.
Because we aren't just watching superficial disease over a decade. We are watching the absolute most complex presentations.
The kind involving extensive bowel work, exactly.
So with the best possible surgical execution mapped out by MRI, what actually happened to these women as the years ticked by? Let's get into the big numbers.
Okay, so the study had a mean follow-up of 60 months, which is 5 years.
Okay.
And tracking the probability of needing a repeat surgery over time shows the steady, really predictable creep upward.
So where does it start?
At 1 year post-surgery, only 3% of patients needed a repeat surgery.
3% is great.
It is. But at 3 years, it climbs to 11%.
Okay, creeping up.
Right. At 5 years, it hits 18%. 7 years is 23%. And it maxes out at a 28% probability at the 10-year mark.
Wait, 28%. If the master mechanic removed all the visible rust from the car, why are almost a third of these cars back in the shop a decade later?
Well, what's fascinating here is how the paper frames it. Is it new rust forming, or is it microscopic rust that was left behind and just grew back?
Yeah, exactly. Which is it?
The paper makes a sharp distinction between recurrent lesions and the further development of incomplete removal.
Okay.
In many lower quality surgeries, a second operation is really just finishing the job of the first one.
Because they didn't get it all.
Right. But here, because the surgeons systematically verified the complete macroscopic removal of lesions, we have to assume these are overwhelmingly true recurrences.
Meaning the disease just fundamentally recreated itself from scratch, despite a perfect excision.
Yes. It really proves the progressive nature of endometriosis. Surgery is highly effective at managing it and providing relief, but the disease process is still active in the body.
It's just not an absolute cure.
Exactly. It is rarely an absolute cure until a patient reaches menopause. Interestingly, though, the average time between the first and second surgery in this cohort was 46 months.
46 months. So that's almost 4 years of relief, on average, before needing to go back to the operating room.
Right.
That feels pretty significant when you're, planning your life, your career, your family.
It is significant. A previous study out of Bern, Switzerland, found the mean time to repeat surgery was around 32 months.
Oh, wow. So this French study got an extra 14 months of relief.
Exactly. And that likely reflects the thoroughness of the initial deep excision and the value of that preoperative MRI mapping we talked about.
Extending the symptom-free window by over a year is a massive quality of life improvement for a patient. But, hearing that 28% of women need a repeat surgery within 10 years, it makes it so easy to assume the absolute worst.
Oh, for sure.
You just assume the pain returned full force, the disease aggressively came back, and the surgery just flat out failed.
Right.
But diving into why they went back to the operating room completely changes the narrative here.
It totally changes it. So out of the 1,092 patients, 155 had a second surgery.
Okay, 155.
And 108 of those were for true recurrences, like a relapse of pain.
Okay, so that's the pain coming back. But what about the rest?
Well, that leaves a significant number of women who went back to the OR for entirely different reasons. 39 of those surgeries, which is about 3.6% of the entire study population, were related to infertility management and IVF.
Wait, really? So we're talking about proactive procedures then?
Yes, exactly.
Like doing a salpingectomy for a hydrosalpinx or managing recurrent endometriomas specifically to, preserve the ovaries for egg retrieval.
Right. A surgery to facilitate a pregnancy is goal-oriented. It's not a failure of the first surgery in the way we traditionally measure surgical failure.
It's a calculated step in a broader reproductive plan.
Precisely.
It's kind of like a home renovation, if you think about it.
Yeah.
Going back to the hospital isn't always because the roof is leaking again. Sometimes it's because you're trying to build a nursery.
That's a great way to look at it.
You're expanding and prepping for IVF. So if a chunk of these surgeries are for IVF prep, the actual failure rate of the endosurgery is much lower than 28%.
Much lower. And get this, the single most frequent repeat procedure overall wasn't actually an excision of recurrent endometriosis lesions.
What was it?
It was a hysterectomy for adenomyosis. There were 45 cases of this.
Adenomyosis, so disease in the muscle of the uterus itself.
Exactly. Because the majority of these patients were nulliparous, meaning they hadn't had children yet and wanted to preserve their fertility, the surgeon had to leave the uterus intact during the first procedure.
Even though they knew the adenomyosis was there, just sitting in the uterine muscle, they had to sort of work around it to keep the door open for a future pregnancy.
That's exactly what happened. They conserved the uterus to allow for those pregnancies. But as the years went by, the adenomyosis continued to drive severe pain relapses.
Because it wasn't removed.
Right. So once those women were done having children or decided they just couldn't bear the pain anymore, they returned for hysterectomy.
So the highest rates of repeat surgery were actually driven by the initial, entirely necessary decision to conserve the uterus and ovaries.
Exactly.
Wow. So the 28% isn't just, the endometriosis came back.
No.
It's the endometriosis came back in some, we had to do IVF prep in others, and we finally took out the uterus because the patient was done having kids.
That is exactly what the data shows.
That is a completely different emotional landscape for a patient looking at these odds.
Very.
I mean, it shifts the perspective from this looming threat of failure to a much more manageable multi-step healthcare journey.
It gives patients agency. And knowing why women return to the operating room naturally requires us to look at how we prevent it.
Like it.
When the researchers ran the numbers through a Cox multivariate model, which is a statistical way to isolate actual independent predictors from the noise, they found two statistically significant factors that reduce the probability of needing a repeat surgery.
Okay, here's where it gets really interesting.
It does.
Because the first protective factor aligns perfectly with the adenomyosis data we just discussed, right? Hysterectomy.
Exactly. If you take the uterus out, your chances of needing another surgery drop significantly.
Makes total sense.
And the second protective factor the model identified was postoperative pregnancy. Women who got pregnant after their surgery had a significantly lower risk of needing a repeat operation.
Okay, but this brings up this huge contradiction in the paper.
The pill paradox.
Yes, because the doctors in this study explicitly recommended that patients take continuous birth control, like taking the pill back-to-back to stop their periods entirely.
Right, as a way to prevent the disease from coming back.
But when they ran that Cox model, continuous postoperative amenorrhea did not show up as a statistically significant protector. The math literally said the pill didn't significantly help. So was the standard medical advice totally wrong? Should you just throw your pills away?
No, definitely don't throw them away. This is actually a perfect example of why you can't just read a statistic without understanding the human lives generating it.
Okay, explain that.
The data didn't show a lack of biological efficacy. It showed a behavioral constraint.
A behavioral constraint.
Right. Think about the two protective factors we just established, hysterectomy and pregnancy. Many of the women in this cohort desperately wanted to get pregnant.
Oh, and you obviously cannot get pregnant while taking continuous birth control.
Exactly. The women who were trying to conceive had to stop taking their continuous hormones. They had to allow their cycles to return, sometimes for months or even years, while trying to get pregnant naturally or going through IVF.
Ah, I see. Because pregnancy was such a major goal for so many in this cohort, the usage of the pill was highly interrupted.
Highly interrupted.
They weren't actually in continuous amenorrhea because, well, life got in the way. The human behavior, this deep desire for a family, totally skewed the statistical model.
It did. The continuous pill likely does work brilliantly to suppress recurrences, but only if you actually take it continuously for a decade.
Which these women didn't do.
Right. The data paradox exists because real women don't live in controlled laboratory vacuums. They stop their meds to build their lives.
It's so easy to look at a p-value in a medical journal and think you have the absolute truth, but you really have to look at the messy human reality behind the spreadsheet.
You really do.
And speaking of the spreadsheet,
Yeah.
in any 10-year study, you also have to look at who falls off of it.
Right, the loss to follow up.
The researchers noted a loss to follow-up of 5.6%, which honestly seems pretty good for a decade.
It's remarkably low for a decade-long study. It really speaks to the dedication of the clinical research technician managing the cohort, hunting down responses year after year.
Definitely.
And to ensure the integrity of the findings, the researchers pointed out that even in a worst-case scenario if all 65 women who vanished from the study did go on to have a repeat surgery elsewhere, the overall rate would only shift to about 19.8% at that specific snapshot in time.
So the data is incredibly robust, even with those missing people.
It is.
Though they did mention a few caveats, right? Like some of the data relied on self-reported questionnaires, which can introduce recall bias.
Right.
And severe bowel endometriosis was massively overrepresented in this group compared to the general population.
That's true, and that's because this was a tertiary referral center, so they were inherently seeing the toughest cases. Which means the average person with superficial endometriosis might actually have an even lower risk of repeat surgery than what the study suggests. The 28% ceiling we see here is heavily influenced by the complexity of the initial disease state.
Wow, that makes total sense. So looking at the big picture, what does this all mean for you? If a patient is sitting in their doctor's office tomorrow, staring down the barrel of an excision surgery, how should they use this information? Does this study mean they should demand a hysterectomy, or should they feel safe just doing an excision?
If we connect this to the bigger picture, the ultimate takeaway is profound optimism coupled with strategic planning.
Optimism. I like that.
Yeah. Nearly 3 out of 4 women, about 72%, will not need another surgery within 10 years after an expert complete excision.
72% stay out of the OR for a decade. That just proves that expert surgery works.
It works, and more importantly, it gives patients the power to make an informed, personalized choice based on their actual life goals. If you want to preserve your fertility, you can go into this knowing you might have a slightly higher risk of needing a tune-up surgery later down the line. Perhaps for IVF prep or to manage adenomyosis once you've had your children.
It's just part of the plan. It's a phased approach to your health.
Exactly. Conversely, if you are absolutely certain you do not want future pregnancies, this data provides massive leverage.
In what way?
Discussing a first-line hysterectomy alongside the excision of your endometriosis could drastically lower your risk of repeat surgery. It could potentially save you a decade of battling adenomyosis pain.
Because you aren't just relying on your doctor's gut feeling anymore. You have a decade of data from over 1,000 women standing right behind you.
Yes.
We started this deep dive talking about the anxiety of the unknown, that fear of the invisible roots growing back. We unpacked a 10-year, 1,000-plus patient study and found a landscape that is just much brighter than the raw statistics initially suggest.
It really is. And while the data comes from one highly specialized French hospital, the biological truths it uncovers, like the progressive nature of the disease, the impact of adenomyosis, the effectiveness of complete macroscopic excision, these truths belong to everyone. They are universal baselines.
It really is incredible, and it leaves me with this final thought. If tracking just one Maunder surgeon's patients over 10 years yielded this many aha moments about how to treat endometriosis, imagine what could happen if we built a global unified database.
Oh, wow.
Right? What if the surgical techniques, the MRI mapping, and the 10-year outcome of thousands of surgeons were tracked and analyzed by AI? Could we eventually predict your exact, personalized long-term outcome before the first incision is ever even made? It's definitely something to ponder. Thank you so much for joining us on this deep dive.